My name's Trevor Hancock, and for those of you who weren't here last month, why not? But for those of you who weren't here last month, I've been organising this season's set of talks, and the set of talks is called Health in the City. It's not about healthcare. So if you came here thinking it was going to be about healthcare, this would be a good time to go. Because what we're talking about is how you make cities more healthy. And so this really, in many ways, picks up where I left off, not where I left off, but it picks up on some of the issues that I raised, but takes it much more into the experience of Jason Corburn, who is our speaker, both as an academic, but also as a practitioner in terms of his research out there working in and with communities in his local region, but also around the world. And I also want to link Jason and what he does back into some of the origins. And I talked last month about the work that I did with Len Dool at Berkeley. And Len was a professor of public health. He was actually a psychiatrist who got involved in the whole issue of cities and was cross-appointed into environmental design. Well, Jason comes from the other direction. So he's an urban planner who's been cross-appointed into public health. And really he's sort of carrying on the work at Berkeley that Len started. So he's an associate professor, jointly appointed in the Department of City and Regional Planning and the School of Public Health. And he co-directs a joint master's program in city planning and in public health. So you can go to Berkeley and get a joint master's in city planning and public health. And I actually know there's someone in the audience here I know who's quite interested in doing that. His research, as you will learn, focuses on the links between environmental health and social justice in cities. And so what he also brings to this is not just about city planning, but it's about how you do that and how you do it in communities and with communities. And with a strong focus on the links between the social and the physical, the links to health equity and to social justice. And he describes himself, and I'll just read this to you, as committed to engaged scholarship, which to me means using research and the resources of the university to promote change, particularly social justice. In my own work, this most often happens through partnerships with community-based organizations and governments, but also includes foundations and international agencies. And in fact, he works with communities in Africa, in Latin America, as well as in the US, and he'll draw on all that experience as he talks with us. He's the author of two really interesting books. One is called Street Science, which is a title I just love, which is about how you engage with people, and based on his doctoral research, and how you engage in the co-production of knowledge with communities. And then the second book, which is this book, called Toward the Healthy City. And I just want to read you a quote from the first page, because I think it sort of covers, describes Jason in a sense and his interests. How can modern city planning, a profession that emerged in the late 19th century with the goal of improving the health of the least well-off, but lost this focus throughout the 20th century, return to its health and social justice roots? What are the connections among contemporary city planning processes, not just physical outcomes, and health equity? What new political processes can help reconnect planning and public health with the focus on addressing the social determinants of health inequities in cities? And so that's, you probably don't need to come and say anything else, that pretty much does it, right? Jason Corburn.
Thank you, Trevor. Can people hear me? Do I have to be closer? No? Okay. It's wonderful to be here, and also when Trevor Hancock emailed me, no one calls each other anymore, and said, hey, could you come up to Canada and talk about your stuff on healthy cities during this session? I didn't really have to think twice, as Trevor has really been a great inspiration and real leader globally in this field, and has influenced my career, my own work in many, many ways. So it's a pleasure to be here, and thanks for inviting me. So I'm going to try to be provocative and hopefully entertaining and that you won't fall asleep, and talk a bit about my own work that tries to connect, as Trevor said, health and city planning, but with a very explicit equity or social justice lens. And I'm going to try to convince you about what matters for healthy cities. And I'm going to try to make the case that planning matters. Planning is not one thing. But as Trevor mentioned, in the theme of this talk, this series is that medicine, healthcare alone, even public health alone, can't make cities, and particularly urban populations, specific urban populations, healthier, as this is now the century of the city, an urbanizing planning. And related to that is not just planning, but that place matters. Not just space, but I'm going to talk about place, and what does place really mean? And that geography, not genetics, often determines life chances for many city residents. Where you live often matters for your life chances. And that ought to be unacceptable to us as planners, public policy people, government officials, academics. And ultimately, policy really matters. These are public policy questions and challenges. And as Trevor, I think, made the case in his talk last month, and I will briefly suggest tonight, is that centuries of policies at the national all the way down to the local level have created this landscape of inequalities that we currently are grappling with. And things like urban design, so central to the field of urban planning, and now reconnecting with ideas from public health and social epidemiology, are necessary but insufficient to move towards healthier cities. And I'm going to try to ground all this in my own work in some places around the world, in the San Francisco Bay Area, in Rio, and in Nairobi. So fundamentally, I believe cities are good for us, and urban living is good for us for lots of reasons, some of which I will just briefly highlight here. Education and employment opportunities, especially for women and often marginalized populations. Cultural and religious tolerance. It's not by accident that the Arab Spring is happening or happened in cities. Greater services and social supports often happen in urban areas. Environmental sustainability and addressing climate change in terms of less consumption or energy use can also be beneficial in city living. Political expression. Cities are clusters often of innovation, technology, ideas, new medical technologies emerge, and off medical care. People come to cities, good hospitals, good care is often in urban areas. But more importantly, for us and for me in my own work, and I'm going to try to convince you that within city inequalities, it's not enough to say X city is healthy. We need to look within particular neighborhoods, within particular districts in a city. And within city inequalities, which I'll define as preventable exposures, preventable morbidity and mortality, are rising both in the global north and south, again, as this planet urbanizes. So it matters where you live in a city to understand whether it's healthy and equitable, and how that city is governed. This is Mumbai and pavement dwellers living along railroad tracks. And to quote Rudolf Virchow from a century and a half or more ago, who was a doctor who investigated an outbreak of typhus and government of, was working for the government, and they expected him to report back as a clinician what were the causes of this disease, health, lack of care, some exposure, and his report, which is now his work has become quite infamous with thinking about medicine as a political endeavor, that he wrote, "It's no longer a question of the medical treatment and care of this or that person taken ill. You cannot begin with palliatives. You must start by inciting the population into a united effort for political change for health." So the politics, organizing, bringing community together, central in 1848, and I would argue through today. And situations like this that we see in Sao Paulo today where the richest of the rich living next to the poorest of the poor in a favela are not by accidents. These are not just random events. In fact, these are very common. Why? Because the poor folks living in this favela work domestic servants and clean the homes and the pools and the rest of the rich who live right next door. But these are often a function of policies and planning decisions, historical and contemporary. Let me give you a couple examples to set that up. And I'm going to argue that if we want to move towards healthier cities, we've got to indict planning and its related practices as sort of community malpractice for things like this, which is a picture of urban renewal. And what you're seeing on your left is Pittsburgh, Pennsylvania, in the 1950s, a vibrant hill district, one of the homes of American jazz music, African-American population, but also was labeled as blighted by public health professionals and said this is a slum, this is a blighted housing, degraded, polluted community, poverty-stricken community. And federal policy in the United States, housing policies, a series of policies said, let's bulldoze those communities and rebuild a more modern city. And what you see on your right is, I guess what you would like here in Canada, is the Pittsburgh Penguins hockey stadium was built in that location. But urban renewal and the destroying and bulldozing of urban neighborhoods, particularly of the poor, immigrants and communities of color, was a common practice. And remains in some ways a common practice for some in planning. And it wasn't just in developing countries like the United States that this happened, but it also has a long history in Brazil, which I'll talk about some of our work in Rio. And this is a similar urban renewal strategy in the 1930s of destroying a favela and rebuilt modern housing there. And even today, in contemporary post-colonial Sub-Saharan Africa, and this was Nairobi, Kenya. You're seeing a colonial plan for the city in 1948, which focused on design and improving the city largely through urban design, which was the strategy that came from British urban planning, to slum planning today, which remains predominantly, although I'll make the case that there is an alternative, about governments bringing in bulldozers and raising, in the name of public health, hygiene, and sanitation, many urban poor communities. So we've fast forwarded to today, and the field of urban planning, at least parts of it, have begun to reconnect and speak to planning in many ways. Some images here from recent books on designing healthy communities in the UK, shaping neighborhoods and delivering healthy communities, and the World Health Organization has even recognized this. But I'm going to make the case that this connection of design, of traditional land use and planning is necessary but insufficient without an explicit attention to policy and without an explicit attention to social justice. Again, I'm going to try to convince you through some practical cases that as planners or urban policy folks, we need to stop pretending that healthy planning is only about design and learn from the history, the missteps and the opportunities that social, racial, economic, and environmental justice are crucial aspects of moving towards healthier cities in rich and not so rich countries. We need to stop segmenting functions of city planning, so a transport department, a public health department, education, environment, housing, and all the rest, all off doing their own things, rarely talking to one another. And think more about integrated communities and integrated systems, and how might we do that. I'll hopefully give you some practical examples. And part of a systems approach, I would argue, for planning is that we're going to get it wrong more often than we get it right. But that's okay. That doesn't mean don't act as if we were in a laboratory where we would wait till we had conclusive evidence, maybe until we made a recommendation. We can't wait in planning and in public policy. We need to make decisions and adapt and learn about what is and what's not working over time by including things like robust monitoring and robust community participation. Deep democracy is a central component of moving towards healthy and equitable places. So let me try to ground some of these ideas in my own work, and I should say that in all of these cases I'm part of a team which includes my students, which includes community-based organizations, often local government in each of the cases. So we have a regional health equity approach in the San Francisco Bay Area. The book that Trevor showed, I talked about some specific work we've done over the last 7 or 8 years in San Francisco. Tonight I want to talk a little bit about a city called Richmond, which is just north of Berkeley in the San Francisco Bay Area, very working class, poor community, a lot of environmental toxins, a lot of poverty, and a lot of people of color, immigrant community. And part of what we've done is to look at the geography of health in our region. And this map shows these vast disparities in life expectancy, differences in life expectancy based on your zip code, a geographic area of where you might live. And the dark red is showing the lowest life expectancy and the green the highest. And what we have just a few kilometers away, one of the richest parts of the United States, is a 15-year difference in life expectancy, often driven by your neighborhood and where you live. And that's just unacceptable. So this is again a bit of a drill down of life expectancy by census tract. And again, the red, lowest life expectancy, green is the highest, and the yellow in the middle. And what I want you to do is just keep your eye on the red areas. Those are East and West Oakland in particular in these maps. And so what we do is if we show basically any contributor to morbidity, respiratory disease hospitalizations, same neighborhoods, highest rates. COPD, again, more respiratory illness hospitalizations. I could show you asthma hospitalizations, same neighborhoods, same adverse impact. Heart disease, same thing. And then if we were to map poverty on top of this, we'd see the same relationship. So something is going on, not by accident. That place, race in this case, economic opportunity, and health outcomes and determinants of health are spatially patterned. And so this is not a dynamic that's unique to the San Francisco Bay Area. This is different cities in the United States and counties, in the East Coast, the Midwest, industrial cities, southern cities, state of California, see the same dynamic. And what you're seeing here is mortality and neighborhood poverty groups. So what we've done is categorize neighborhoods by poverty, and what you're seeing is the lower the poverty group in the neighborhood. So this is not just individual poverty, but area-based poverty measure, the lower the mortality rate. And the higher the poverty, the higher the mortality rate. And also in the United States in particular, this is deeply, deeply coupled with race and ethnicity. So what this is showing is from 1960 through today, we have a widening gap between whites and African Americans, and this is showing life expectancy over time. So that everybody is living longer. Public health would say, hey, we're doing something right. Everybody's living longer. Something must be, we must be doing something right. And we probably are. But the disparities, the differences between different ethnic groups are growing. And again, this is not unique just to the San Francisco Bay Area. So what might explain this? Too often in public health, we're running to, or in planning, we're running to one intervention, reducing one risk factor, so stop smoking, don't drink so much, change your diet, or maybe if we designed more walkable communities, people would exercise and change their behaviors. We've tried to take a different approach. We've tried to just take a step back and say, what are the different multiple contributors to these health inequities that I just described to you? And our hypothesis is something around cumulative stress over someone's life course, so from in utero through maturity and old age, hopefully old age. So a set of stressors that are social, from stigmatization and discrimination to environmental toxins and pollution, to stress around housing and finances, to access to food, and a whole host of other things, crime and violence, wear away at the body's immune system. And this is not my idea. I'm borrowing this from a host of researchers that focus on something called the weathering hypothesis. So you can imagine the weathering the sea air does to a building or the paint outside of a house, and wears that away over time. But you can repaint and repair. It's hard to do that in the body. And the weathering hypothesis says that our body biologically responds to these stressful events, and that's a good thing. The fight or flight mechanism. A hormonal release happens when there's a stressful event that triggers our body to protect vital organs and release hormones. And then there's a recovery period, and that hormone release shuts off. And that's kind of the normal biologic response to external, environmental, social stressors. But under the weathering hypothesis, and in these neighborhoods with chronic, cumulative stressors from housing, poverty, crime, discrimination, those events continue. They happen in utero, and they happen at a very early age, and they continue to happen. And the immune system never fully shuts off. So there's this chronic stress. And as we age, we often develop behaviors to respond to those. Things in public health we tell you not to do. Don't smoke, don't drink so much, don't eat such terrible food. So this combination of stress and high effort coping, which can often be unhealthy behaviors, contributes to this biologic mechanism of this constant hormonal release, which can lead to this constant feeling of hunger, poor glucose regulation, and the chronic illnesses we see widely, both in rich and increasingly in developing countries and in cities in particular. Overweight and obesity, hypertension, cardiovascular disease, asthma, stroke, etc. Autoimmune diseases. So this is our driving hypothesis. There's lots of other evidence I can talk about later to support this. So one intervention around physical activity, or just around housing, or just around changing people's behavior won't get us, in our view, to this to address these cumulative stressors. Okay. So back to Richmond, California, and what have we done there? Over a series of about 5 or 6 years, we started with putting a health element into the city's general plan. So the state of California requires a general plan for each municipality, and the required elements of that plan, sort of chapters about what you want, how you want your city to develop, kind of the constitution, the blueprint for development, include things like housing, land use and transport, and other things. They had never before included health. We're the first city in California, one of the first in the United States to develop a health element as part of the long-range development plan for the city of Richmond. But as a planner, we knew that was and that took 2.5 years to develop. Lots of community participation. It included a lot of those maps I showed you earlier. But as a planner, I knew that what we do really well in planning is make really thick documents and put them up on a shelf that nobody reads. So how could we change that dynamic? How could we use this momentum around health and equity to actually build off the plan to implementation? So we designed this partnership, which was an implementation strategy, a long-range implementation strategy that involves the city. The city itself doesn't have a health department. It works in the county, so bigger geographic area has a health department. Berkeley and a host of community-based organizations, and the school district. So we recognize that schools are often anchor points around which people interface with services, including obviously young people. So we have a series of programs that circulate around our health equity model and our Richmond Health Equity Partnership. I just want to highlight a couple of them. So we've really focused on bringing full-service clinics back into schools, which have been basically completely wiped out in the United States, although we're really part of the original part of public school, the kind of services schools would offer. bringing in clinics, but really at prevention and training young people in health promotion to get into the healthcare field more as health promoters, not just on the clinical side, but that can start as early as in high school education. And to get into this kind of pathway out of poverty through engaging in the healthcare system. The city of Richmond is one of the most violent cities in the United States. At one point it was about the third or fourth highest homicide rate in the city, in the United States. We developed a program called a Peacemaker Fellowship through an Office of Neighborhood Safety, which is direct outreach to gang members and engaging them in trying to change their life around and trying to get in. Our Peacemaker Fellowship is actually based on a Latin American model of conditional cash transfer. So we pay these guys small amounts of money to get a driver's license, a passport, to get a high school education, a whole bunch of things that then can get them jobs and get them off the streets. We've developed a health and all policy strategy, which is anchored around this practice of health impact assessment. So thinking about all the functions of city government with a health lens and using a health impact assessment framework to do that, which includes building health equity measures into the city's budget, and training and getting community members into positions of power was also a key piece of this strategy. So we've gotten community members elected to school boards, planning boards, and even to the city council in Richmond. Much of this takes lots and lots of time of community building, community organizing, and working through the schools and through existing community-based organizations. This is an article from the New York Times talking about this shift in perception and practice in Richmond, and a quote from the mayor of how she believes that they've turned the corner and really showing how a city can change its work, its thinking, and its planning, and changing its policies to focus on health. So thinking about violence, housing, city services through the framework, through the lens of health equity. And you can get much more information and all the details on our project, which is still ongoing, at richmondhealth.org. One of the things we've really been committed to do is to measure our progress along the way, not wait for a third-party consultant to come in and tell us what we haven't been doing, but to develop indicators as part of the process and try to measure how well we're doing. And so this is a sort of preliminary list of some of our indicators. And they try to measure both process, what is changing in terms of city decision-making and access for people, and some health outcomes. So it's not an exhaustive list, but it helps give us a sense and is contributing to what we're calling the city's health equity report card, which they will be reporting out annually with their partners. So one example of how we're trying to bring health equity and an integrated strategy around these cumulative stressors into city management and city planning. We shift to a different part of the world, again a partnership between Berkeley, State University of Rio, and some non-governmental organizations. And really, this project started in part as it was a long history of policy development in Rio around favelas, or informal settlements, the poorest communities in Rio. And as Brazil's economy has taken off, part of the BRICS countries, right? Brazil, Russia, India, China, and South Africa, really seeing them as the leading economies of the world. Inequality has also increased, and particularly in cities, and not just in Rio. This is where we've been working. So the favela population, they actually do, the city does a favela census, or they do an urban census and a favela census for the entire country of Brazil, which is quite unique. And the 2010 census was just released last year. We've been analyzing these data. And the favela population in Rio, larger than any other city in Brazil, it increased over 28% in the last decade, while the city as a whole only grew about 4%. So what's going on? We're not exactly sure what is going on, but the reality is that poverty and inequalities continue, and they're rising, just like in, I showed in the example in the United States, in Brazil. Brazil also, as part of its rise, has attracted, as sports fans might know, the World Cup will be in Brazil next year in Rio, and the Olympics in 2016. And as part of both of these events, and a long history of policy and social policies in Brazil, there's an attempt to integrate the favelas, the poorest neighborhoods, into the fabric of the city, an explicit policy. This map shows where the special Olympic planning zones are currently, and where intensive development, sort of Olympic Village and other kinds of infrastructure, including transport and other things, are happening intensively now. And part of our project was to say, how can we make this planning, this development, accountable to the needs of the favela residents? And so we partnered and were approached by a community-based organization called SEDAPS that has worked for many years on a host of issues. They got started working primarily on HIV/AIDS in the 1980s and shifted to develop a network of community-based organizations focused on accountable and equitable development and interventions to improve the health of favela residents. And so they've really tried to focus on preventing displacement and gentrification, valuing youth and culture, bringing services, including health care. And this particular example, I want to emphasize that linkage between planning and the clinical side of medicine and public health, and providing economic opportunities, often employment opportunities, through a program that they call their Plataformas program, which is really their urban centers program. And this is just a map from SEDAPS of, they kind of build and connect existing community organizations that might be doing something that folks don't see as explicitly linked to health, but they help them see the connections. And they built a network that they call the Rio Healthy Cities Network of over 140 different community-based organizations in different favelas to work together, share stories, build alliances, and work to hold this development and these policies, some coming from the national government, some at the municipal scale, accountable to local needs. And I'm just going to give you one fairly quick example. So part of a policy called Favela Barrio was an intensive investment in infrastructure, social programs in favelas since the mid-1990s. It's now connected to some of this development happening around the Olympics and the World Cup. So SEDAPS, through their Plataformas program, has really tried to connect their work through the formal planning that the city and the state government have organized through these, what they call their urban and social guidance centers, these PUSOs. And what they are literally community centers in many ways, where almost like a development office, a construction management office that's in the neighborhood. So a development project comes into the community or is planned. This would be the office where an architect, a developer, an engineer, excuse me, also social workers would be to engage people, to engage community organizations, and to start a public process around that development project and the design of it with residents. Now, SEDAPS has inserted themselves strategically into this process to also link Brazil's national universal health system, which is a centralized health system for everybody, but decentralized in its implementation. So it's implemented at the city level and often at the neighborhood scale. And one of the major success stories of Brazil's healthcare system is their family health program, which is literally a community-based clinics of prevention and basic clinical care. So what they've done through their Plataformas program is to begin to link this planning office, which is really about ensuring that housing and infrastructure and social programs happen in communities, with these clinics that are funded by and supported through the national health system. And a number of things have happened, including moving residents who are in insecure housing towards tenure and more secure housing, and improvements in infrastructure. These are the official statistics from the government of Rio and something called Fiocruz, which is the research arm of the Ministry of Health. So infant mortality in the last decade through this and related programs has been halved. Literacy rates improved. Connections to water, toilets, and electricity in favela homes. So these are not community facilities, but private water taps, private toilets, and individual electricity. What we find, though, with SEDAPS is that they don't believe these numbers. And so what we're doing, in part, is doing, with our partners, our own surveying and mapping to hold the official statistics accountable to what local people think are really the ground truthing for them. And it's another form of organizing and holding accountable some of these development projects that claim, in some cases, to be delivering when community residents don't necessarily see the benefits. Last example from, again, a different part of the world, similar dynamic in Kenya and in Nairobi. Again, very challenging living conditions, informal settlements in the city of Nairobi. About 65 to 70% of the city of Nairobi, of about 5 million people, are living in informal settlements. So this is not the exception. These are not small pockets of poor neighborhoods. This is the majority of the city. And if you look across Africa, particularly Sub-Saharan Africa, that is, informal settlements are the norm, not the exception. So if we can't plan, as planners and public health and public policy folks, for the majority, these informal settlements, then what are we doing? And I don't think we have our priorities straight. So again, this is a partnership between Berkeley, the University of Nairobi, and a host of community-based non-governmental organizations. We situate you a little bit into Africa and Kenya on the East Coast. This map is not projecting that well, but I'm going to talk about some work that we're doing in an informal settlement called the Mathari Valley. This map is showing the city center of Nairobi, which doesn't mean a whole heck of a lot. It's a British colonial planning which spread out the city as kind of urban sprawl. But you may have heard of a settlement called Kibera, which is generally talked about as the largest slum in Africa. It's in the bottom left, that red blob there in the corner. The Mathari Valley is also about the same size as Kibera in terms of population. It's also one of the most challenging places in Nairobi and in Kenya to plan because it's got a lot of ethnic conflict. In fact, Kenya is having elections in a few days, and the previous elections that some of you may have heard about had a lot of ethnic violence, and the urban violence was situated in this informal settlement called Mathari, where people were of different tribes were killing one another. So our NGO partners stepped in to try to both do conflict resolution and part of that poverty alleviation and planning, and link that to now a new constitution that Kenya passed in 2010. Give you a little more context to this informal settlement in Mathari. This is typical housing, pieced together with sheet metal, dirt floor, often dirt walls. Very informal is an understatement. It's called the Mathari Valley. It's an area with steep slopes, people living on the sides of slopes that drain into a river. This is the Mathari River during the dry season, and again, it's hard to see. There's a bridge there, and during the rainy season, all of that white stuff you see there is garbage, is waste. This water rises and floods these low-lying homes, shacks that you see along the river's edge. So a lot of infrastructure, environmental challenges, but it's literally the drainage for much of the development, the formal development in the city that's up on higher ground that then drains into this informal settlement. This is a typical water access point. I want to point this out because a lot of the work that we've focused on with our partners is on basic infrastructure and its relationship to health. Some obvious ways and some maybe not so obvious ways. So this is looks like a perfectly fine public water tap, but what the image doesn't really portray is the social dynamics that are happening around this. So this is controlled by a local gang where they extort money from people to use this. They tap into the municipal system, illegally, which changes the water pressure and gets water contaminants into the water, etc. So it's a whole host of not just local environmental and public health, but social dynamics around water and sanitation, electricity, and a whole host of services. And so our approach is really to take a social, see this as a social intervention before a physical and even public health intervention, which means organizing and building community power to change dynamics. So when you fill up that jerry can of water, you then have to haul it back to your house or wherever you're living. And as I mentioned, this is on a steep slope with a river two rivers running through the valley. So lots of hazards. This is not just for people living there, but imagine in an emergency or a fire truck trying to get in here, it just doesn't happen. So a fire breaks out because of some informal wiring in someone's home, and literally hundreds and hundreds of people, sometimes thousands, are left homeless and displaced because there's no emergency services that can access. Of course, sanitation, toilets. This would be, according to the World Bank, an improved pit latrine and would count as an improvement under the Millennium Development Goals. And we're in a big fight with the UN and the World Bank around what they measure as improvements in a place like Nairobi. To us, this is unacceptable in a modern city, but for some, this is an improvement according to the Millennium Development Goals. And I'm going to say specifically what we're doing about this in a moment. This is the municipal sewer system that literally drains and is dysfunctional and drains into surface drainage in this community. But it's not all negative. I don't want to portray this place as negative. There's a lot of life, a lot of intelligence, a lot of innovation, both from young people, people who come here. And so tapping into that is part of our strategy. Just to make the point about urban living being healthy, even in a place like Kenya. So this is showing child mortality, and in the informal settlements in Nairobi, you see basically more than double the child mortality than in the city as a whole, and higher than even in the rural areas. And most global health tends to be focused on a model of rural health, and so not as successful thinking about the complexities of urban informal settlements and what that would mean as a public health, not just a medical intervention. Our approach to informal settlement health is what we call our integrated or relational model. And in the book and in our model, we just somehow got stuck on P's. So we've got, again, a focus on process. I'm going to say much more about that in a second. But not ignoring the physical and the place-based resources or lack thereof. There's assets and liabilities in these places. Partnerships are really critical, so we work with local government and community-based organizations and international donors. They play a big role, sometimes too big a role, in what goes on in these places. And ultimately, it's about building power and changing policy. It's not about boutique projects or volunteerism, but it's about really structural change. And let me give you a sense of how we're trying to do that. The process starts with our partners literally trying to make this invisible population, these are informal settlements, to make them visible. And that means that the government often doesn't recognize them. How do we do that? Well, they literally go door to door through an enumeration and counting and surveying community members. In fact, community members are trained to do it themselves. That leads to both a planning process and organizing locally a very small micro savings group. This is not microcredit, but it's micro savings where people save very, very small amounts of money every day to build, really to build social cohesion more so than financial capital, although the capital does help. And the organization we work with is a network of micro savings groups across all of Kenya, linked to an international network of micro savings groups called Slum Dwellers International Networks in 24 countries around the world, where they share experiences. They also share capital to leverage investments, private investments from donors and the private banking community. But the surveys and the mapping, again, put these communities on the map, make them visible, both to themselves and to government and other decision makers. And that contributes to a participatory and collaborative planning process of now deciding what are the priorities here, what are the challenges in this place, what do we know about existing conditions and what needs to change. And so these are some images of our planning process with residents and students from the University of Nairobi and Berkeley. Some of our survey, one of our most recent survey, found some things that those of you familiar with informal settlements in Africa might find quite common. Less than 10% of households have in-house piped water. Again, remember that community water tap. 15% a private toilet. Many have to walk great distance. Remember the topography. Food is the largest expense, single largest expense for people in this community, and too often we heard from often single women, mothers, skipping meals for their children or trading sex work for food. So to recognize these linkages, this connection in our relational model, these data help us make that case. It also helps us kind of put on the map the real poverty, extreme poverty, food poverty in many ways that residents in this community face. Let me give you a couple quick examples of what we're doing, and then I'll wrap up. So this is a map of the water points, these public water taps in the community. And what you're seeing, this is 13 different villages, about 200,000 people. That's a neighborhood or community where I come from. I'm from New York, where a neighborhood is 150,000 people. I realize that there's not many cities in Canada that are that big, but nonetheless, 200,000 people into a number of different villages. This one on your upper left has had quite a bit of organizing and intervention around water, which is why you see more water taps, but not a lot of water service, basic service in this community. What we've done is to take our data and compare it to international standards. So the SPHERE humanitarian standards are sort of what is the minimum in an emergency, post-earthquake, post-tsunami, of the number of people you would want to see served by a water tap. And that's that red line there, 250 people on average. This is what we see on a regular daily basis, sort of chronically, in a place like Mathari in Nairobi. You see the same thing in Kibera. So we focused most of our early work on water, and in that one village and now across the entire community of redesigning the water system, tapping it, getting resources from the water utility to upgrade the infrastructure and build both communal water taps, which is what you see here. This is a kiosk where people, is now run by a community-based organization, not held by local gangs, and this is the first informal settlement in Kenya to have private water taps, metered taps in people's homes. So you can actually, for the first time in an informal settlement, you can purchase a meter from the water utility and get metered water. Remember, people are already paying for these services, often much, much more than we would pay in a rich country for much better service. So they're not asking for it for free, they just want it regular, clean, and often in their own home. I talked about the World Bank and community toilets and the Millennium Development Goals. These are other examples of community toilets. These are public facilities. Now, this is what, right now, a major intervention in Sub-Saharan Africa is focused on, particularly in Kenya, also Uganda, Tanzania, is community facilities, washing and toilet facilities. We mapped these as well, and also found these great inequalities according to the Sphere Humanitarian standards. You can imagine hundreds of people using one toilet. And unfortunately, the irony is that many people have access to high technology, SIM cards that they can bank with and exchange money, but not a private toilet. So in our view, this is not a technology problem. This is a social and political problem. And of course, this is also a public health problem. And in some ways, we helped publicize these data with Amnesty International. This was a report, BBC, on how lack of safety around this infrastructure, these community toilets, which are more and more being built, leads to, because there's no lighting, there's no security, women face rape and sexual violence regularly around these facilities, so they don't use them. But that can also lead to, and has led to, increase in HIV infection and stigmatization and marginalization of women. So the lack of infrastructure leads to this cascading effect, particularly on women and children in these informal settlements, in ways that it's not just dirty water contribute to. So part of what we're doing is trying to take the lessons, and this is now about 7 or 8 years of work that I showed you in 10 minutes, into what we now have as an opportunity in Kenya. Again, they had a new constitution in 2010. Now they're writing the laws, and a new law that's in fact modeled after Brazil's informal settlement policy, their national slum upgrading and prevention policy. So how do we take the lessons from community in Nairobi and in other cities and turn it into policy is the challenge that we're working on now. And I guess I'll have to come back and report on how that works out. And we'll probably have a lot to do with the elections next week. But the idea is that we want to think holistically about the city, what its residents need, and how to promote equity and health. And I want to leave you, and in all of the examples, we try to take an integrated approach, and I want to leave you with an image of the machine, right? And most of how we've looked at public policy or urban planning or cities is as a machine. And we take apart the pieces, we find the experts that know that one piece, that one bit, whether it's transportation, just like we often do in medicine. Take apart the body, we fix your arm, and hope you know how to walk. There's just this disconnect between how we've segmented the body, how we've segmented cities. And what we're trying to do, and our approach, is really to think about keeping the system together. And knowing that the experts are the folks who are often living inside the system on a daily basis. So keeping that system whole and focusing on the whole system, not just taking its parts. So to conclude, how do we move hopefully towards more healthy and equitable cities and city planning? Again, policy matters. These small projects are trying to contribute to policy change at both the local and the national scale, and that they're needed to address this cumulative disadvantage and those stressors I talked about that drive our work and the hypothesis. That institutions matter, that it's not enough to have projects or small programs. We need to rethink the institutions of policy, of planning, of medicine, and link, again, these often disparate, fragmented sectors that continue to dominate in both public health and in urban policy and planning. And that planning matters, but really, to a large extent, it's still broken, although it's trying to fix itself and with help from others. And we need to learn from those missteps in history and to change our priority and to really refocus the field explicitly on equity and social justice. And part of that means also rethinking the role of science and data and research, and what we often do in the academy, and that rethinking the role of evidence and the role for community experts in generating appropriate evidence and interventions as key piece of this strategy of moving towards more healthy and equitable cities for the 21st century. I'll stop there. Thank you very much.
We have got lots of time for comments and questions, so I'm just going to. Do you want to handle the questions, or do you want me to pick up?
I'll take the easy ones. You can take the hard questions.
Using the company speaker. Well, just while we're waiting, let me ask you a question. I've not done a lot of work in situations like this, but I'm always impressed by what I learned from them. And I used to say, why can't we be Sweden? But in recent years, I've been beginning to think, why can't we be Brazil? There's fascinating things happening there. What do you take from working in Brazil and working in Kenya that you can bring back to Richmond, and how do you use that?
Yeah, that's a great question. I would agree that I think there's more to learn from Brazil than there is from the United States, or Canada's doing some good things, so I wouldn't include Canada there. But I guess kind of what I talked about would be what we've taken from Brazil and tried to bring to whether it's Kenya or Richmond. And so maybe 4 or 5 things. One is really know the context. I think what's powerful and important about Brazil is they try not to generalize, even with national healthcare system or national social policies, and they have some very interesting ones, still accounts for in their policy the local context, so different cultures, different needs of ethnic groups, and a recognition in some ways of place-based challenges. The second related thing that I think Brazil has done very well is think about leadership from the top down and the bottom up, so kind of a treetops and grassroots strategy. So we've got real leadership, particularly from the past president and current president in Brazil, of social policies, poverty alleviation policies. So all that economic growth, using that for some social good. Programs like Bolsa Familia, which some of you may know, which is one of the most successful poverty alleviation programs ever in the world, taking over 10 million people, 20 million people, out of poverty in 10 years through a conditional cash transfer program linked in part to public health objectives. But then decentralizing, like I noted, the health system and the community clinics to the neighborhood level. So policy that supports at the national, but also implementation and control of certain aspects of that at the local level. And not, and I guess part of that leadership at the national level has been to, which would be the third idea from Brazil, is this integration of health and planning and social policy. So the World Bank, of all places, wrote a study of poverty alleviation in Brazil, and one of their conclusions was that the success of poverty alleviation programs, and I don't know if we should believe the World Bank on poverty alleviation, but they said was not the poverty alleviation program itself. In many places around the world, Europe and others have had great or very progressive social policies. But what was important and one of the most successful dynamics in Brazil was that poverty alleviation at the national level was linked to local planning and local resource, access to schools and clinics for people to comply with some of the provisions of their social policy, and not afraid to make those explicit linkages in Brazil. And I think most importantly for all this is that there's a rich history of organizing social movements in Brazil to hold all this stuff accountable. These progressive policies don't happen just from leaders, elite leaders. They happen from strong social movements. And Brazil's approach to AIDS, HIV/AIDS in the 1980s and 90s was one of the biggest public health success stories in the world, was from strong social movements. And I think the work there today, similarly, our partner SEDAPS again comes out of that, but strong social movements. And so that's what we're trying to, our partners do in Kenya and in Richmond.
Okay. Thanks so much, that was really stimulating. I just had a question about the use of the term equity, which it seems like a really fascinating aspect of justice to emphasize. Two questions though. One, most of what you discussed seemed to talk about meeting basic needs across several metrics, which seems really right, but didn't talk a lot about the relative difference between the affluent and the poor, say, or the health needs. Is there anything in the policy and so on that addresses the bridging of the gap that way, or is it primarily about making sure that those who are most underprivileged have certain basic needs met? And then the second question, I'm just wondering how you respond to people who promote a kind of rising tide floats all boats sort of theory that says, hey, at the end of the day, it doesn't really matter if someone's making 100 million and their poorer neighbors are making 100,000. It's just that the 100,000 people are actually having all their needs met.
Yeah. Trevor, you want to take this question? Good questions, thanks. So the equity as a frame, yeah. I mean, it's not one thing. I hope that came through, and that, again, there's some context specificity there in terms of defining what those indicators and basic needs are. So they're not the same, and in fact, even in a place like Mathari in Nairobi, we see great variation across the same informal settlement in terms of immediate needs, medium and longer term needs, both what community members tell us and what we're able to identify in terms of people having access to water, sanitation, electricity. Some have more organizing power than others, and there's a whole kind of embedded dynamic just in this community of about 200,000 people. So trying to understand that helps us move towards what does equity mean, and in part that's defined by local people and their articulation of needs and the organizing strategies that are used. I don't know if I answered your question, but it's definitely in a comparative perspective in the sense that the poorest of the poor can't improve their living conditions often without also basic services and infrastructure in the city and often the region also improving. So we need to address the regional housing market in the San Francisco Bay Area for the issue of foreclosures and kind of economic violence in Richmond. So it's not just a neighborhood or city-specific issue. And in Rio and in Nairobi, similar challenges, often around infrastructure and transportation. So the benefits of improving the plight of the poor also address issues for everyone in the city. The neoliberal claim that just getting the rich richer will trickle down and create employment. I don't know. I don't see any evidence that that's worked, since the 1970s anywhere in the world. So if you can show it to me, then I would say, okay, maybe we could think about that as a model. But since it doesn't work, hasn't worked in Europe, hasn't worked in my view in North America, clearly not in South America. We're seeing what's happening now in Asia, China, for example. What are alternatives? And so we're trying to develop at least an alternative that says the state has a much bigger role here than we've been led by many to believe in markets, in development, in urban policy, and we shouldn't be afraid, I know you in Canada are not, of an interventionist state.
And if I could just add one other thing, in addition to all of the focus we've had, a lot of it's been on water and sanitation and so on, but another thing certainly I've seen in Brazil that's crucial to all of this, which is what Len Lewin called the soft infrastructure, is primary education and access to primary education. I'm sure you've seen that in those places too. Yes?
Jason, you talk about, policy matters and governance matters. What do you see happening with, something that's evolved in the last couple of decades, which is the growth of the real mega cities in the world? I'm just back from Mexico City, which I think is somewhere around 22 million or something like that. And many of these cities that show signs of growing forever and growing infinitely. And the old concept of a, quote, municipal government seems really antiquated and just doesn't work. What do you think might happen or should happen in terms of governance of mega cities that are as big as many countries?
Yeah, great question. It is in part for me a governance response and an institutional response. So I think you're right that many of the municipal scale institutions are not in a position really to respond to that. Again, I would point to places like Brazil, and to some extent there's some things happening in the US where the national government sees a role in place-based policy, and that it partners, creates new partnerships with municipalities and states. And so that's kind of the academic response, and in practice that means we probably need new forms of governance at a different scale for these mega cities and mega regions. Some people point to a place like Portland, Oregon in the United States, one of the few places where they've been able to kind of draw an urban growth boundary and focus growth in, and have stronger county scale governance than just a small municipality. I think there's a whole host of challenges that are going to go into that. I do see, for example, some hope in climate policy, for example, where we see cities, not national governments, taking the lead and being proactive in climate action plans and the rest. I think in this urbanization and health equity challenge, we also need to see cities being leaders and mayors, not governors or heads of state, taking the lead to forge better solutions.
I just want to comment on, I appreciate your choice of terminology and saying, instead of calling them slums and that kind of thing, it has an equalizing and empowering sense of the poor being every bit the same as the rich. Appreciate that.
And welcome that. In fact, the term favela, for those of you who know Brazil or worked there or in Rio, is not really an accepted term. So if I was giving this talk in Rio, I wouldn't use that word. I would talk more about community or neighborhood. So the language does matter. I agree with you.
Although interesting enough, Slum Dwellers International call themselves Slum Dwellers International.
Thank you very much for the wonderful presentation, as I said, very stimulating. One of the points that really stood out to me when you were talking about your work in Rio was one of the civil societies mentioned an opposition to gentrification. They clearly listed that as a part of the mandate of their organization. So that got me thinking about how some of these community efforts that you're involved with, how those people involve themselves and how they define their equity and what it is they want their neighborhoods to look like. Do they aspire to those big high-rises that we saw next to the favelas, or are they looking for something different, something grounded in a different sense of community? So I'm just interested if you can comment on how some of these folks in these informal communities, how they define what it is they're looking for, and how, you know, partnerships with your universities say how they can help them achieve that.
Yeah, good question. So I mean, I think the reflection of the sophistication of social movements in Rio in particular, in Brazil, is a recognition that, you know, sort of these planning and urban development schemes have often led to displacement of the poor. This may be one reason why favela population is growing, because they're actually very strong social networks for people. People don't necessarily want to leave for lots of reasons, but they want improvements. So part of the strategy in Latin America is somewhat unique in Brazil in particular. Moving towards protection from displacement for the urban poor has not been widespread tenure or ownership of housing, but more a negotiated agreement between government, often structure or land owners, and residents. So part of that prevention of gentrification has been to really be strong social movements engaged in that negotiation, and making a real stand about services and needs in their community, even if they don't have legal, quote unquote, legal protection of title to that structure or the land where they live. So that's been a somewhat unique strategy, whereas in Nairobi it's completely different. It's all about very much individual households getting title to land and or title to the structure, its ownership of the structure. So that's a longer conversation, but the more general point is that having an organization that's able to negotiate with the state and with the private sector and with developers to ensure that there isn't widespread displacement when a new escalator comes and serves that community, or when new infrastructure is served there, or a community center or a new school goes in. How do you ensure that the residents who live there can benefit from that and don't get displaced? So being organized and being able to negotiate for what you want has been a key piece of that strategy for SEDAPS.
Thanks for your talk, Jason. I enjoyed it a lot. I'm curious about these conditional transfers. So you said that you had implemented a program like that through the university, and then you talked about that also in the Brazilian context as being one of the most successful anti-poverty approaches in history. When I think of conditional, I mean, I associate conditional cash transfers with those kinds of measures in, for example, the American welfare state and aid to families with dependent children, where that's been regarded as, I think treated historically at least, as pretty coercive and not community driven, right? So I guess that's more removal of aid under certain conditions, or removal of transfer, but in some ways this might amount to the same thing. So I'm just curious, what are the ethical dimensions of those kinds of programs? Can they be community-based? Are they community-based? How are you guys doing it at Berkeley? I'm just curious about that.
Yeah, so let me clarify a couple of things. So we're not doing that at Berkeley. Part of the Richmond Health Equity Partnership is a program called the Office of Neighborhood Safety, which has what they call their Peacemaker Fellowship, which we support them, but it's run through the city of Richmond. And that fellowship is actually a conditional cash transfer program. So they go out and actually recruit gang members, and they give them small amounts of money for conditions, doing certain things in the Peacemaker Fellowship program. I mentioned some of them. Yeah, there's some coercion there for sure. I think it's a bit different though than sort of American-style welfare. It's based on, in large part, what came out of Mexico, the Oportunidades program, and now in Brazil, the Bolsa Familia program, which is also conditional cash transfer. So people in poverty are required to do certain things like keep their kids in school, send them to primary and secondary education, get them immunized, a few other things. And based on that compliance, they get money from the state. So there is some coercion. The incentives are seen as social goods, both to the individuals, the families, and the larger society. Again, what's seen as successful in some ways in Brazil and in other countries that have adopted this is not just the cash transfer itself, but the physical and social infrastructure around the program that supports people to participate and take advantage of things. So in other words, you can't keep your kids in school if there's no school there, or if you need them to be working or doing some other service. So making sure that those other things are in place in order for people to comply and take advantage of the program. So it's a piece of some of these strategies. I don't want you to get the impression that it's the only thing, whether it's in Brazil or in Richmond. Yeah.
Just following up on the Richmond case, are these, because the data that you had looked very impressive and very hopeful, were these pilot programs, or is there some kind of longer term sustainability, and what is the funding model for those kinds of things?
Yeah, great. I'm glad you asked that. Thank you. It started as a 2-year pilot, and part of that pilot, our strategy, and when I say our, it was our team at Berkeley and community-based organizations in Richmond, an organization called Policy Link, which is a non-profit group in the U.S., and something called the California Endowment, which is a healthcare foundation, which has changed its strategy to focus on funding places and not diseases. And they've made basically a 10-year, $10 billion strategy to invest in places, and this kind of integrated approach. And it's an experiment that they're trying. Richmond is one of those places. So they funded our pilot, and then our strategy in the pilot was to build community pressure to get the city government and the county government to make this a regular part of their everyday function, to get the city manager to see that the function of the city on a day-to-day basis can include and ought to include health equity as the driving framework, to get the city council to endorse the work and adopt it through an ordinance and legislation, a health in all policies ordinance, to get the mayor, as you saw in that New York Times quote, to see that their approach and her approach to governing the city is making health and equity a key piece. And so that was a political objective, and I think we partially achieved that. We now have those commitments from the city. And we were really clear we didn't want this to be a boutique pilot project only. We wanted to try to institutionalize it in these and other ways. The Office of Neighborhood Safety is actually a new department within city government. There's other examples I can point to. So that's the kind of sustainability strategy for us. It includes a lot of involvement also by the school district, which is also kind of a core institution in all of this. The funding strategy comes from a couple of streams. Some is that the city's budget is now being tied to some of those objectives, those indicators that I showed. So they have a 5-year budget plan, business plan, and each agency now has 2 indicators that they're responsible for. We still get money from the California Endowment, a private foundation, to keep this work going. And part of the political change that happened largely through not our work, but community-based organizations, was to get 2 new people elected to the city council, which changed the balance of power and got a resolution passed in the city to get Chevron, one of the largest oil companies in the world, which has the largest refinery west of the Mississippi in the United States, in Richmond, to pay their taxes. And they hadn't paid any property tax in 30 years. And you can imagine why, with their legal team. So they got a measure on the ballot to change the tax structure to make sure that Chevron paid its fair share of taxes. And that is now $60 million a year to the city of Richmond. So, and that just started last year, 2012. So we've taken a kind of multi-pronged sustainability strategy.
If it's any consolation, BC Ferries just tried to employ the Chevron strategy here in BC, get out of paying taxes. But anyway, go on.
Rio is going to be hosting the, as you said, the 2014 World Cup, or
Yeah.
16 Olympics altogether. Both those organizations, FIFA and the IOC, when they go through their selection process, look at the social agenda that's put on the, put into the big process. We went through the 2010 Winter Olympics here, and there was some social agenda. It was fairly minimal, and I had the feeling it was kind of pushed on to both the provincial, national, and local organising committees. London has done a fairly extensive job in the East End of London around 2012.
Yeah.
What's happening in Rio? Is there, I guess the first question is, was there any thought on the part of the national government when they bid for those that there was the possibility of there being an extensive social agenda, because they're going to be spending billions building stuff. So was there any thought there? And in fact, how has that had, if there was or there wasn't, what spin-offs have there been, or do you hope that there will be?
I mean, I don't know all the thinking that happened at the national government. I'm pretty confident to say, though, that the reason Rio was selected was in part because of some of its success around its social programs, particularly under Lula. The response that I'm more aware of is at the community-based organization, the civil society level. So there was a lot of organizing, and there remains to be. I'm not trying to portray this as a success story broadly, but there are aspects definitely of success to ensure that the social agenda was at the forefront of the development process, as I talked about. Once these nodes of development, Olympic Village and World Cup stadiums were identified, there was very focused organizing by a range of civil society groups to ensure that the agenda was really about social inclusion and not displacement. That hasn't worked out perfectly. There's lots of stories, and the international press is talking more about the negative than the positive. There are some positives of transport, and the big one that's happened, that's been from the national government down to the neighborhood in Rio, has been what they call their UPP program, which is their urban pacification program. You've probably seen this on the news, where they actually bring the military into the favela to pacify, drive out the gangs and the drug dealers and the rest. And everybody kind of hates those scenes of big arms and the rest. But what's been different? Lots of countries do that. Beijing took all the homeless people and drove them hundreds of kilometers outside the city and got them. That was their strategy. But in Rio, they've explicitly followed, I think in part from this pressure from civil society groups, with a program called Social UPP, which is a very concerted effort to bring social programs, infrastructure, housing, economic development to immediately follows this quote-unquote pacification, to really bring both social and economic benefits alongside some of the physical that's already happening around these development nodes. So I think that was remains an explicit policy from the national down to the local level. Is it perfect? No. It's got its challenges, but I think in general, my sense is that the social UPP program is benefiting many, many favela residents.
And if I can add an interesting twist on that I saw a year or two ago in Belo Horizonte, where
they deliberately did not put a police station into the favela. What they put in was a primary school and a recreation centre and a conflict resolution centre using volunteers. And the police drive through the favela a couple of times a day, but they don't have a base there. And so it's an entirely different twist on it, which seems to be working really well from what I was told. Okay, any more? I have a question for you folks, actually, because it shouldn't all be one way. You don't have to answer this right now. But what do we take from this back to Victoria? What are the lessons in this for us here about what we can do and how we can do it, or should do, and how we should do it? I mean, this isn't just about how do you fix things in Rio or Richmond or whatever, but we need to think about what do we take from this and bring back here. We're not Rio, we're not Nairobi, we're not even Richmond, but there are lessons, I think, to think about at least. I think we've got time for one more question if there is one. This side of the room's been awfully quiet for a while. Okay, Bob.
You know, to answer your question, you know, one of the things I heard is about joining up government here. You know, that in fact, you know, take it down now, you know, but, you know, the need to make sure that all levels of government don't work in those silos. How do we do that across those silos? How do we get, as Trevor and I have been talking about, how do we get health and recreation and planning all talking together as opposed to you know, up and down the side?
Yeah, I mean, to go back to some of the examples in Kenya, they've actually recognized some of this. So they have a program called the Kenya Municipal Program where they're retraining all their civil servants because they've been trained in a very kind of colonial mentality of very segmented, expert-only approach to civil service, and many have never set foot in an informal settlement, and that's 65% of the city that they're governing or their bureaucracy is addressing. So major retraining of professionals, and of course, in my view, we got to think about how we retrain this new generation of public health planning and policy folks to go into government, civil society, or the private sector. Thanks.
So I want to thank Jason for coming and sharing his experience and expertise with us, and a lot of fascinating information there, as I said, just thinking about how we bring some of that back here. Just in closing, 2 or 3 things. I want to thank the Urban Studies Committee, which is the committee at the University of Victoria that sponsors this series, the City Talks. I would like to thank the Legacy Art Galleries for their space, and they've asked me to remind you, please don't touch the artwork. I know you're not going to, but Raylene would like to remind you to like us on Facebook, www.facebook.com, The City Talks. Follow us on Twitter, @City Talks. There's a website, The City Talks, www.thecitytalks.ca. And finally, I'd like to remind you that 3 weeks today, Sharon Friel will be here from the Australian National University. She was the Director of Research for the WHO Commission on the Social Determinants of Health, the Global Commission, then led something called the Global Research Network on Urban Health Equity, and she's particularly interested these days in the relationship between the social determinants of health and climate change and social equity in cities around the world. So I think it'll be sort of building on what Jason has been talking about tonight. So thank you all for coming, and we'll see you, I hope, in 3 weeks' time.